The following podcast will discuss the principles of anesthesia for pediatric thoracic surgery. When planning anesthesia for thoracic surgery in a child, it is important to recognize the factors influencing the management. Among them are the child's preoperative condition, the underlying disease, and the effects of surgical manipulation. As a child's anatomy and physiology change substantially during development, management can vary a lot. No single solution fits all patients. Every patient merits an individualized concept, focusing on specific airway management and an analgesic regimen adapted to the surgical and patient needs. In the following sections, the key points for anesthetic management of pediatric thoracic surgery are to be discussed. Starting with airway and respiratory management, significant differences exist in children compared to adults. Small airway dimensions influence the management. Respiratory physiology is characterized by high airway resistance and a tendency towards lung collapse, resulting in atelectasis and shunting. An even worse ventilation-perfusion mismatch combined with high oxygen requirements increase the risk of hypoxia and hypoventilation. Prematurity and pre-existing lung disease can aggravate these problems. For many thoracic procedures, one lung ventilation is desirable. The aim is not only to facilitate surgical access and to avoid mechanical trauma of the lung. Protection is also required against soiling and air leakage. The choice of an adequate device for lung isolation is guided by the child's airway, anatomy, and size. The use of the rather bulky double-lumen or univent tube is restricted due to its size to children older than 6 to 8 years. Bronchial blockers and mainstem intubation with the standard endotracheal tube are possible at nearly every age. Bronchoscopic control is generally recommended. How relevant is analgesia? What about neuraxial anesthesia? In adult patients, especially those with limited pulmonary function and extended resections, a functioning epidural can improve the patient's outcome. Within the last years, positive effects of regional and especially neuraxial anesthesia have become evident also in children. Regional anesthesia avoids the exposure to potentially neurotoxic effects of systemic drugs and can prevent hypersensitivity in newborn and very young children. In nearly every age group, optimized analgesia can result in lower rates of respiratory complications. Techniques as paravertebral and epidural analgesia are successfully applied. Nevertheless, the impact on the patient outcome is less clear in pediatric than in adults. A higher primary failure rate, a more preserved lung function in many patients, and a lack of well-controlled pediatric studies could explain this. Are there any differences in the clinical practice compared to adults? First, regional anesthesia in young and rather uncooperative patients is usually performed under heavy sedation or under general anesthesia, both with an acceptable risk. Nevertheless, skin to epidural distance is short, the epidural space is quite narrow, and the loss of resistance technique is made less distinct as the yellow ligament is much softer. This means that the margin of safety is small and requires an experienced practitioner. Some authors consider paravertebral blocks to be a safe alternative, as the distance to the spinal cord is greater. Intercostal blocks can be an option for less painful procedures. As sporadic reports on spinal damage exist, and the effects of neuraxial anesthesia on the pediatric outcome is less convincing, a thorough evaluation of the individual risk and benefits seem to be prudent. Regarding pharmacology, there is an increased risk for accumulation and toxicity due to the imaging metabolism and more permeable blood-brain barrier. Ropivacaine seems to be relatively safe. The risk of accumulation is low in children older than 3 months. As it comes to epidural opiates, sufentanil offers the most favorable pharmacological properties in this age group. The next part will focus on surgical access in general and specific aspects of common entities. Thoracoscopy results in reduced musculoskeletal trauma, in less pain, and enhance recovery. It can offer better visualization for the surgeon. Open surgery is reserved for extended procedures and is more stimulating and painful. One-lung ventilation is desirable for both modalities. In thoracoscopy, insufflation of carbon dioxide can improve visualization. Potential side effects to watch are hypercarbia, hypothermia, and increased intrathoracic pressure. This can be limited by low gas flow and reduced insufflation pressure. Regional anesthesia limits postoperative pain with these negative effects. Adapted to the extent of surgery, epidural and paravertebral anesthesia, as well as intercostal blocks, provide adequate analgesia. Within the following section, frequently encountered surgical disease will be outlined. Empyema is a common complication of pneumonia in children, with an increasing incidence. Main points are the presence of sepsis, the respiratory compromise including the presence of secretions. If antibiotic therapy and chest drainage do not result in clinical and radiologic improvement, surgery is indicated. Primary thoracoscopy is performed with increasing incidence. Open procedures are reserved for complicated cases. Protection against soiling and reducing the ventilation-perfusion mismatch on the affected side by lung separation is very important. If copious secretions are present, a preoperative bronchoscopy via supraglottic device is recommended. Pleurectomy and decortication are painful procedures, highlighting the need for regional anesthesia. Tracheoesophageal fistula. The main goal when providing anesthesia for a child with tracheoesophageal fistula presenting for a surgical repair is to bypass or exclude the fistula to avoid gastric distension and aggravating respiratory failure. For years, the standard or textbook anesthetic approach has been to maintain spontaneous ventilation and avoid positive pressure ventilation. Recently, it has become evident that in children with a small fistula and in the absence of pre-existing respiratory compromise, controlled ventilation is relatively safe. In children with a pericardial and a large fistula, exclusion of the fistula by distal intubation one-lung ventilation is recommended. Carbon dioxide insufflation can be used in thoracoscopy and to optimize access. The perioperative risk is increased in premature children and those with pre-existing respiratory failure. Neuraxial anesthesia can facilitate weaning and favor early extubation. As a summary, when performing anesthesia for thoracic surgery, the anesthetist needs to integrate the physiologic interaction, combining influences of the disease, surgery, and the patient's pre-existing condition. Within the perioperative context, adult management cannot be simply transferred. Every patient merits an individualized concept focused on airway management and optimal analgesia in order to provide excellent anesthetic care.